is Charles Bailey. I am a pediatrician, and as pediatricians, we like to think in developmental metaphors. So if you will, what I'm going to do is walk you through the baby book of a network called PedsNet, which is just reaching its toddlerhood in trying to realize learning health principles in an academic pediatric setting. Right, so PedsNet is a collaboration among large academic pediatric health centers that was consciously formed to try to embrace learning health system principles following an IOM roundtable in 2009 where a bunch of us got together and endorsed the concept of learning health systems, in particular for improving the health care of children, a context in which we have much more fragmented utilization and a much wider variation between healthy children, where basically our major responsibility is to protect them from infectious diseases, ensure adequate nutrition and education, and stay out of their way, and children with complex medical conditions who need a variety of increasingly interrelated technical interventions. So by way of history and by way of the landscape, after this initial sort of conceptual collaboration, 6 of these organizations got together and over about 2 years focused on feasibility studies, some of which I'll look at a little bit, and then rolled forward into a collaboration with a quality improvement organization called Improve Care Now, which is a collection of now close to 60 different centers who treat children with inflammatory bowel disease, and which have demonstrated that the application of some fairly straightforward learning health principles and quality improvement principles can actually shift rates of clinical remission in this population of children significantly. Currently, PedsNet is an 8-institution collaboration that's funded by PCORI as a clinical data research network. So one of the data aggregation and integration networks that's based around health systems. And you can see here the names of the 8 health systems that have gone in together to create the PedsNet CDRN. So what does this mean in practice? So PedsNet at its core has a collaboration that is designed to improve our ability to do pragmatic research and pragmatic studies that help us understand the way populations of children go through life and receive their health care. Part of that is a technical and informatics challenge. So it consists of a data network that addresses questions like putting the data on a level footing so that you can ask the same question in Philadelphia and Seattle and Denver and Cincinnati. Some of that is just the mechanics of being able to reach, in our case 4 million, in PCORI's case 50 to 100 million different patients with a query in a way that is reasonable in terms of time, in terms of cost. Some of it has to do not with the informatics and the data, but it has more to do with the process of research. How do we bring down the regulatory barriers that have made it difficult for the kinds of large collaborations that you need to conduct effective, quote, big data, unquote, or learning health system research? What are the methods that you need to study these, both in terms of the ways to account for confounding, as Dr. Tannen was talking, in large kind of, if not truly retrospective, at least convenience data sets, or what are the ways to do distributed analytics that more adequately protect patient privacy? And then one of the key dimensions that we need to bring into the process of research as well as patient care is how are the patients and families, for us as pediatricians, engaged not just in the process of donating data or not just in the process of being the targets of research, but in the process of actually informing what it is we need to learn and informing what meaningful outcomes are, right? So I said this is our baby book, and you can see a sort of picture of our infancy in the United States. This is a much more heterogeneous healthcare system than the UK, and everybody kind of pulls their pieces together. So at this point, we have a bunch of islands in the Big C, and as the blue shades off across this, you can see the coverage of PedsNet thins out. So part of our goal is spreading the message and spreading the collaboration to make some of those white areas turn blue and some of those light blue areas turn darker blue. Right? But where are we now? So we have a data network that encompasses about 4.5 million children. So that's about 3% of the children in the United States, even though we have all of these big gaps in our geographic coverage. We have a fairly broad sex, race, age, and ethnicity distribution. And we capture data on about 58 million visits for children from birth up to about 20 years of age. Right? The data model is currently partway to Dr. Tannen's list of prerequisites, right? So we're currently capturing and providing a uniform surface of excuse me, concepts for things like diagnoses, healthcare received, visits to physicians, that sort of thing. We still have some pieces of the puzzle that we have to expand to. Some of that is new types of data, things like better capture of medications, better capture of laboratory results, significantly patient-reported data as well. What are the kinds of things that are going on outside the doctor's office and outside the hospital that are important determinants of outcome? But for all of that, we actually have, excuse me, a number of good steps down the road toward the complex mixture that we need to do the kinds of studies that we've been talking about. Right? What you see in particular in the lower right-hand corner here probably looks like the kinds of snow that was usually followed for those of us as a certain age by a message, do not adjust your TV set. This is a technical problem. And what I'm showing there is from place to place and from time to time the different mix of diagnoses that kids have in this network. The point here is not to be able to interpret any one of the dots, but simply to look at the abstract art that produces and realize that this is not a simple process and that what we've been able to do is accumulate a meaningful amount of information, not just about the healthy kids whom we need to immunize and feed and educate and stay out of their way, but also about children with IBD, children with cancer, children with heart disease, children with asthma, and other common and less common diseases. Now, I talked about pulling a lot of data together, and I realized that I'm talking to a sympathetic audience. You at least connected to this webinar, but I think it's still important to address the question, why are we doing this? Why are these 8 centers taking the time to be the vanguard for a national pediatric learning health system? Part of the reason is very pragmatic. We need to create these kinds of collaborations. In order to know how better to treat patients and how to make that research generalized, not just to my patients or your patients, but patients everywhere, we need to engage in massively collaborative or massively parallel in the big data terminology research, and that requires collaborations and relationships among people, among providers, among healthcare systems. It also requires decreasing the regulatory barriers, not only to sharing the data, but to sharing the research. And critically, it requires including the family, so building the structures that allow patients to have meaningful input into the design of research, the prioritization of research, and the reporting of outcomes. All of these things taken together are intended to make possible things that you can't do otherwise, because you don't have 50 million patients, or in our case, 5 million patients, because you don't have input from the patients on the outcomes that are, A, important to them as the consumers of healthcare, but B, are the kinds of things that are going to drive whether they continue to participate in healthcare. As has often been said, a medication is only as effective as the patients who take it. And so if you're missing the factors that determine whether or not patients can or can't take the medication, then your research is not going to be anywhere near as effective. It also helps us to do standardization, not as a goal in itself, but as a way of creating that kind of a uniform landscape so that I can ask a question that's meaningful in Philadelphia, in Seattle, in Denver, in Cincinnati, and Boston. What's the value of this to us? Well, partly this result rests in the size of the population. We have the power to ask questions we couldn't ask otherwise because they deal with rare events or because they're subject to variations in individual measurements. We have the opportunity to reach out to over 4 million children to say at any point in time if there are only 3,000 children with a particular condition or a particular set of factors who would be interested and eligible for a clinical trial, we have the collaborations and the mechanisms in place to reach them. And finally, this is much more efficient because we're not inventing the wheel study by study by study, reinventing the data collection, reinventing the data standardization, reinventing the data analyses. We have the system at the ready so that things can move forward much more rapidly and they can be much more wise expenditures of healthcare dollars. Part of what this requires is not just the moving of the data and the creating of the opportunities, but actual governance of the research process. That's involved in reducing the regulatory barriers and getting the institutions and the scientists together to do things like, say, we will all agree to the same set of institutional review board procedures for protection of research subjects, And we'll agree that if one of the 8 institutions IRBs reviews the study and considers it to be ethically sound and scientifically sound and adequately protective of patients' health, we'll all take their word for it rather than doing the same thing 8 times. We've been able to conclude data sharing, data use agreements in advance so that we can share data across these sites rather than each study having to take 6 months to put those in place. We can focus in a concerted way on security of the data and on patient privacy rather than entrusting that to small study teams' ability to bring those resources to bear. And critically, in terms of our ability to conduct the research, we can invest the effort in governance of the data and in the methods that produce effective results and carry that forward from study to study. So let's look at some of what that's done for us. I'm going to take some very simple first steps as an infant examples. All right, what I'm looking at here is measurement of body mass index. So this is the bread and butter of people who study obesity and obesity-related diseases, major public health problem in children just as it is in adults. One of the key things here is the scale of the data set allows you to see a lot more subtle variations than you would see otherwise. So by way of example, there is a very carefully done survey called the NHANES in the United States that looks at growth and obesity in children and adults in a very closely standardized way with a well-validated sampling strategy. Looks at about 20 to 30 children per month of age. What you're seeing here, that red line sits at 6,000. So in a data set that's about 2/3 of PedsNet, we're seeing not 30 kids a month, we're seeing 6,000 kids a month. Now, one of the things we need to do in validating this data is be able to address the very reasonable question. Now, part of what makes NHANES is that they invest a lot of time and effort in making sure the instruments are very tightly calibrated, the methods are very repeatable, that sort of thing. Maybe it doesn't work that way when you go into your doctor's office to get weighed. Well, as it turns out, it does. And so what you're seeing here is a dashed green line. Those are the results NHANES gives you for, in this case, body mass index of girls as they grow. The red line shows you what you get out of a learning health system. So 2 things to take away here. The curves are almost identical. We're getting data that allows you to predict growth, predict obesity, predict nutrition out of this, what a statistician would call convenience sample of children, right? And we're getting it with much less scatter because we can look at 6,000 points, not just 30 points. So you see how, in particular, as kids get older, those numbers scatter, the little X's scatter for the NHANES data. It snaps right down when you have higher dimensionality to your data. It's also important for us to be able to see this because it's the primary data that determine, in this case, whether a person is affected or not. What you're seeing here is how often, when we went back and looked at kids where we measured height and weight and knew that a patient was obese, they actually got a diagnosis of obesity. And what you can see is unless they were seen specifically in a weight management clinic, fewer than 20% of these kids attracted the diagnosis. So if your starting point is a national epidemiologic database, or your starting point is insurance administrative data, or your starting point is CDC reporting, you've just missed 80% of your affected patients. We also get some power that comes to us simply from the large numbers. What I'm showing you here is an association between obesity and other complications or other illnesses. And if you look at the top of the chart, you see the usual suspects, right? Obesity is associated with a higher risk of diabetes, a higher risk of HDN hypertension, a higher risk of hypercholesterolemia. But we're also able here to detect rarer associations with cancer, with endocrine disorders, with genetic disorders that you wouldn't see in a data set of 500 or 5,000 patients. It enables us to do observational research, to detect not just associations that we know about, but effects of treatment. So what you're looking at here is a smaller study. We narrowed the cohort down to about 65,000 patients and followed them over a 5-year period and asked, if you were given antibiotics as an infant, did that affect the chance that you were going to be obese by the time you entered kindergarten? And what we can show in a data set like this is that the more broad spectrum antibiotics you're given, the higher the chance you'll be obese 2 or 3 years later. Now, this is an association. We can't prove that the antibiotics are the cause, and clearly part of a learning health system is recognizing when the study method that you're using gives you information on what kind and when you need other kinds of studies to follow that up. But what we have here is an association that we can detect that would have been impossible in a purpose-built clinical trial. We've also been able to look at these data sets and, in a manner similar to Dr. Tannen, show that we can do research about novel treatments. And we can look at the effectiveness of therapies. So this is a much smaller cohort, starting with about 8,000 children who have inflammatory bowel disease taken from the Improved Care Now Collaborative, looking at not just their electronic health record data, but also data that their physicians recorded as part of clinical visits to be part of this registry. And we are comparing the results in green of a traditional randomized clinical trial for TNF-alpha antagonists, a type of therapy for symptomatic inflammatory bowel disease, and what we find with an appropriate trial simulation design in the Improved Care Now data. What you see there is that both response to treatment and actual reaching remission are not significantly different in the randomized clinical trial, 200 patients, and of whom about half were evaluable for this outcome, and in the Improved Care Now data. There's a little bit of a decrement on both sides, and we also think that that's meaningful, even though it's not significant, because it's telling us a bit about the real-world effectiveness of the treatment. This doesn't mean, we think, that the randomized clinical trial was not an appropriate mechanism, and it doesn't mean that either data is better. It means that traditional RCTs, which tell you about efficacy, ideal world impact of the drug, and pragmatic clinical trials, which tell you about effectiveness, real world efficacy or outcome impact of the drug, are both important ways to study therapies. It also means that we can use some of the same sorts of research or analysis methods corrected appropriately for the LHS data to do things like predict survivals or predict remission rates over time. So where do we go from here? We've taken our first steps. We've accumulated the collaborative resources and the data resources to start down this path. We've done some initial demonstrations that the quality of the data and the range of the analytic methods are sufficient to let us ask meaningful questions and meaningfully change the outcome of children who require medical care. Now we need to expand our scope. We're in the process of incorporating patient-reported data into this, this common data resource, and of expanding our data, which is centered around the information that's gathered when you see your doctor or you go to the hospital, to get closer and closer to the NHS model that Dr. Tannen was describing. In the U.S., part of the way you do that is you go back to insurers and ask what administrative data do they hold. You look at other opportunities for patients to contribute data from different sites. We're continuing to refine the research model and the governance as we do more of these multi-site studies and get more information on what works and what feeds forward well, both on an administrative level and on a research level. And we're using that to move into broader partnerships with the groups who are asking the research questions around a particular disease that really sets them on fire. Right? So that what we want is a partnership of the people who whose reason to get up in the morning and enjoy what they do is creating a learning health system that facilitates research, and the people who get up in the morning on fire to answer questions about a disease that their child has or that they have a particular interest in. We want to maintain this focus on pragmatic trials. What we want to do is learn things that change the way we're going to take care of people in the real world. Thank you very much.